Preparing to live stream the meeting. Setting your meeting for YouTube Live. All this will end up on YouTube, you know that. Right, we're on YouTube now. Okay, so I'm going to close that down so that doesn't annoy me. And we're going to get ready to start. So whilst people are joining our live stream, let's have a little icebreaker question, icebreaker kind of thing, just whilst we're waiting for people to join, and then we'll introduce ourselves and all of that stuff. So it's barbecue season because it is the summer in England. I know it doesn't look like it right now because it is grey outside and I have clouds everywhere and I think it's going to rain, but technically it's barbecue season. So what is your favourite thing to put on the barbecue? And I'm going to ask Lynne first.
Sausages.
Oh. You should come up with something. I thought you were going to say something really like strange and exciting.
No, I don't normally eat sausages. So
Okay.
like barbecue, it's like a treat. So yeah, sausages and onions and that sort of smoky smell that you get with a barbecue.
Nice. So any kind of like flavor of sausages or just like normal Cumberland kind of, or just
no, like like you get at an artisan market. I'd like go out and get something special that's got all the herbs in and like things like that. Yeah, so special sausages.
Yeah. So there were some really lovely ones at my butcher's the other day. I think they were like black pepper. They were nice.
Oh yeah.
Yeah. Okay, so Sam, what about you? What would you like to put on your barbecue?
Well, I don't eat meat.
Okay.
Obviously, halloumi is probably my...
We can't hear you very well, Sam. I don't know if you can get closer to the microphone.
Okay.
Or shout.
Is that any better?
A little bit, yeah.
Oh, I wonder.
Oh, there. Now it's working. I don't know what you did.
Does it come back?
Yes.
Oh, okay.
Maybe you just need to be close to the mic.
Fine. So as I say, I'm vegetarian, so halloumi would be my go-to, but
Nice.
some friends of mine barbecue pineapple as a pudding. Yeah, and actually just slightly sort of caramelized pineapple on a barbecue is actually very nice. So that would be my top tip, I think.
Cool. And then Tamsin, you're vegetarian as well, aren't you, most of the time?
Yeah, I eat a bit of chicken and things like that. So yeah, I go halloumi, and in fact, I've got some in the fridge because we were planning a barbecue this evening. So yeah, I've got halloumi. My husband's a total carnivore, so I have to kind of separate everything with bits of tin foil to stop things touching and things like that. So, but I've actually bought him some steaks, and usually he just has a steak and then some sausages on the barbecue, and I go halloumi. And I'd got I had requested some Greek flatbreads in my shopping order yesterday, but they couldn't send them, so I didn't have those, and they've sent me some weird other bread or whatever. So but yeah, so I seem to have a lot of bread rolls, which I'm going to have to get through somehow, but they'll just end up in the freezer and he'll have them for sandwiches, and new potatoes and things like that. And and yeah, I think I've seen recipes for pineapple, so I think that's a good choice to go on the barbie.
Cool. And my choice would be chicken, and I would probably do it in like a kebab style. So peppers, onions, mushrooms, chicken, loads of flavor, loads of herbs and spices, cumin, paprika, that kind of flavor, I think. Yeah, that's my barbecue meat of choice or food of choice. Okay, so we've got a few people on the live stream now, so I think we'll start by introducing ourselves. So welcome to the first ever DSN forum brunch on YouTube. Usually we do this on Facebook, but we had a bit of a technical difficulty the last time we tried to do this on Facebook. I think Zoom has told us off and doesn't like us anymore, so we can't use Facebook. So we've gone on for YouTube because it's the simplest one. It's actually really simple. It's even more simpler than Facebook, so let's hope this works well. And yeah, the first ever live stream on YouTube, and today we are talking about diabetes and homelessness. So it's something that is a really, really important issue. We did have our lovely speakers at DSN Forum Live this year, but for those of you that haven't had a chance to listen to them, they are absolutely fantastic. The work that they are doing is absolutely amazing. So we wanted to bring them on and bring them live so that you guys could ask all of your questions and hear about all of the fantastic, amazing work that they are doing. So I am joined today by Tamsin, my fellow co-host. Want to say hi, Tamsin?
Hello, I'm Tamsin. I'm the lead DSN at Royal Stoke.
And our special guest stars today are Lynne Wolfe. Lynne, would you like to introduce yourself?
Hi, I'm a diabetes specialist nurse working in Bolton, so I've been with them for about 6.5 years. Prior to that, I was a specialist nurse in GP practice for about 27 years. And obviously, a few years ago, we set up this programme for managing homelessness and diabetes. So that's how I met Sam.
That leads us on. Sam, would you like to introduce yourself?
Yeah, so since November, I'm a clinical nurse research associate at UCL, leading a 3-year programme looking at actually improving palliative and end-of-life care for people experiencing homelessness. But prior to that, I spent 12 years as the lead nurse for the Pathway charity, which sets up and supports homeless and inclusion health teams in hospitals. And I have been working with people experiencing homelessness since 2002 after a beginning career in A&E. So that's me.
Oh, so firstly, I think we should probably talk about what kind of it's like to work in your kind of role, what kind of things, what's your day-to-day look like and things like that.
Do you want me to start? Yeah. Okay, so in the Pathway team role, obviously what the teams do is they meet people experiencing homelessness when they come into hospital, and try and use that time to maximise the benefit of the admission, and look at people in a holistic way, not just the reason that they're admitted for, and really try and build up a holistic picture of what needs to happen, connect them in, and hopefully discharge them to somewhere which is going to be safe and effective. It's not that easy, as I'm sure everybody is aware. The housing placements and sort of supported housing placements that we have are very limited. And, with bed occupancy levels being as they are, it can be very difficult to get people discharged to an appropriate place. So in terms of what my life looked like for 12 years, it was often, honestly, supporting staff feeling quite upset about not being able to do what they really wanted to do. As part of that as well, in that role, I've done any number of projects, including the diabetes project. So that job involved looking at all ways that we could improve healthcare for people experiencing homelessness. And that role involved me connecting with wonderful people like Lynne, but lots of people around the country who are doing good work in this area so that we could build guidelines and whatever, but also talking directly to people experiencing homelessness and expert patients, which I am doing now, about their experiences to really kind of understand what we can do better. So I am lucky in that I have a very privileged job, in that I do actually spend a lot of time with people experiencing homelessness, not just as a patient, but also as really trying to listen to them and work alongside them to see how we can improve services. So it's a great role to have.
Lovely, thank you.
Yeah.
Okay. So fortunately, in January, having become 60 years old in December, I managed to reduce my hours to 22.5. Which is, I'm still trying to get my head around that, fitting all the things that I want to do into 22.5 hours, which isn't working very well at the moment. So obviously planning how my week was going to work, we have 2 sites at Bolton. We have the community site and we have the hospital site. So I've managed to, so my week, the way it splits up, my 22.5 hours a week is I do 2 days one week and 3 days another. And it's mainly at the hospital now, so I don't do as much work at the diabetes centre. But regarding my project that I set up a few years ago, managing the homeless with diabetes, I work very closely with the homeless nursing team, and our programme has become funded permanently 1 day a week by the hospital trust because they could see the results we were having. So one of my days is always with the homeless team, and then the remaining days are working at the hospital. The homeless team nurses do in-reach work 3 days a week. And while I'm there, sort of we are looking and identifying anybody who may be homeless that comes into the hospital. We opportunistically screen for diabetes and lipids if they are having bloods, and then I will look for those results. So to improve engagement and looking at sort of safer discharge. For the patients that we identify in hospital, I go and see them every day that I'm in there. If I'm actually not on site, I will ring them so that they have met me and I'm like a consistent person. So that helps to build the engagement that we've achieved. I also work closely with our retinal screener and our specialist foot team. So I do all the foot screening. So the results that I mentioned at the DSN forum, this is helping for us to make sure the patients who are on our programme are managing all their 9 diabetes care processes. So I can manage to get the bloods done and then act on those individually. So that's the way it's working at the moment. I'm just trying to fit, still doing quite a bit in my own time. But, you know, it's easier now that I know I've got one dedicated day for this work.
It's amazing. I mean, it's hard enough trying to get the 9 care processes for people who are not homeless. It must be impossible to do that for people that are homeless, trying to get all of those checks done, making sure that they're seeing somebody regularly, especially foot checks. I bet foot issues are a problem, are they?
Well, they are, but the way again, you know, it may be sort of the way our team work together. But what are the things I do as soon as we identify somebody that has come into the homeless team that has diabetes, I'll make contact. Now we do have a percentage that move on very quickly, so I never actually even get to the point where I see them. But those that I make contact with, again, the way we are able to work, it's flexible working, so I can go and see them. It's difficult if they're on the streets, obviously. But I will do that. I've taken on the foot screening myself. So when I see them, we get the bloods done. I see them for the results and I carry out the foot screening at the same time. And we're doing very well with the eye screening as well, because we have a central centre, which is mainly where all the hostels are and the food banks, etc. So we always make sure the appointment is for the central health centre, and that increases engagement as well, because we do have some sites on the outside of Bolton and they wouldn't be able to get there. So I think when we last correlated the data, I think it was over 64% of the patients on our books had all 9 diabetes care processes enactioned. And we've managed to refer people into the lipid clinic for specialist lipid treatment. Last year we had somebody seconded to us from Wigan, and she was doing familial hypercholesterolemia screening. So I had 4 or 5 patients that actually attended for familial screening, and 2 were positive. So again, you know, they wouldn't have had that opportunity normally. Started them on lipid treatment. Now again, we're always working in the moment, and if they move on somewhere else, I don't know what will happen then, but we know for the time they're in Bolton, they will get that care.
That's really good. There must be some really unique challenges that you face in this work. So things that we as diabetes nurses probably never even think about that you guys have to deal with. Can you think of anything like that, Sam? It sounds like you want to come in there.
Just the first thing I wanted to say was that just to say that Lynne got spontaneous applause for her achievements with the diabetes care process at the Pathway conference, and I mean that is, you know, a massive achievement, and you know, a huge credit to her resilience and thoroughness and all those things. In terms of the unique challenges, yeah, I mean, obviously the people in Bolton are getting very good care, but it is unquestionably true, and this is why I came to this topic, that people experiencing homelessness with diabetes have very, very poor outcomes indeed. And if you look at safeguarding adult reviews, we see people, you know, dying in their teens, their 20s, their 30s, very commonly. One of the expert patients who I'm still now working with has just had challenge after challenge after challenge. And I think, so she has type 3 diabetes. She also has a stoma. And she has a number of other issues. And she's got a history of complex trauma. Lots of very difficult things happened to her in her childhood. She finds it very difficult to trust people. So just getting her into hospital is very difficult. And every time that has happened, it's probably taken, you know, between 5 and 10 goes of supporting her through A&E to get her to stay. She feels like she's being judged. She feels like she's being told off. She finds the whole environment very stressful, you know, lots of noise, lots of people around and stuff like that. So just getting her to engage with treatment is difficult. But on a recent admission, she's in a housing first placement. Her flat was cuckooed, so unfortunately her son broke in and they took over the flat, so she couldn't be discharged to there. And so then we had a number of different temporary accommodation placements whilst they were sorting the flat out when she was discharged, and each one was in a different borough. This is a unique London problem. So they had 2 weeks here, 2 weeks here, 2 weeks here. She had the same GP, so obviously she couldn't be referred to the community services in each of those boroughs. Every one of the temporary accommodation placements didn't have a fridge, you know, for food, didn't have cooking facilities. One was belting hot, one was in the middle of basically a building site. I mean, I sometimes find it so extraordinary that people manage to cope at all. She's on 13 different medications. She's got she needs glasses and she's always using them. She can't read. There are so many different challenges for this poor lady. She's 42. She's actually got 6 children, all of whom she's in contact with. But I would say that the level of support that she needs just doesn't exist in the community. You know, with the demise of the community matron model, Housing First don't support health staff. She just genuinely, you know, all of the things that she needs to do on a daily basis would challenge most of us hugely. Really important to note, so even very simple things, so it's really difficult to trust people. So, for example, a district nurse came in that she didn't know and said, well, you're obviously not eating enough, are you? Well, it's because of the type 3 diabetes and the creon and whatever. And she basically just threw her out. We had a nurse come in. She has got a fentanyl patch because of pain. And she's about 4 stone at the moment. And the patch had fallen off. And that nurse said, well, the patches don't fall off other people. And again, she threw her out because she just feels so judged. So it's difficult on both sides. It's difficult to find the people that can understand and empathise with someone's situation, and people that she trusts not to judge her. So yeah, it can be really difficult. We've just had another death in London of somebody with type 1 diabetes in their 20s, who is somebody experiencing homelessness. We really hoped that the one thing that we could do with this project is ensure that anybody who needs insulin would be seen as priority need. But we haven't got there yet, and it's really important to note for nurses on this project that just being insulin treated doesn't make you priority need for housing extraordinarily. So it is legitimate and you know, not illegal for a housing department to leave somebody who is homeless, who is insulin treated, on the street. I think that probably gives you some of the sense of the challenges.
I mean, that's incredibly sad, isn't it? I think that really, as Amanda said, as diabetes specialist nurses, but you know, Amanda and I are inpatient diabetes nurses, and Beth's a community nurse. So we obviously all have some contact with people that are homeless, but it is a very transient contact, isn't it? That they obviously very often come into hospital because maybe they haven't been able to access their insulin, so they're coming in diabetic ketoacidosis, for example, or they've come in with a severe hypo, for example, probably because of poor access to food or even hypo treatment or anything like those sort of things. But it is very often very, very rapid treatment, rapid in, out of hospital, because a hospital isn't really somewhere that somebody should be if they don't need to be there. And that is really another sad part of the world, in a sense that we don't have enough beds for people anyway, do we? And actually people that don't need to be in hospital are very often moved out of hospital very, very rapidly. And you've sort of talked about it really, but really how do we navigate, in a sense, those issues that people have of either not having access to the insulin because they run out and they, for whatever reason, don't or not able to get those prescriptions, and also, in a sense, those people that are insulin treated that do require access to food, really, to be avoiding coming into hospital because of hypos. Is
Tamsin, can you just move your microphone away from we're getting all your breath.
Oh, sorry. How do we navigate those issues?
So let me give a couple of examples, and then obviously Lynne can give a lot more. So, I mean, obviously I work with a lot of nurses who are really on the front line of things. So I just wanted to credit Kirsten in Bristol. So, for example, she was working with somebody who, for whatever reason, for a huge variety of reasons, does not want to come into housing, and remains in chaos. And she has just systematically made sure that there's insulin. So this person is on opiate substitute medication, so methadone. Made sure that there's insulin and the equipment to test blood sugars at the pharmacy, at the needle exchange, at the drug centre, at the mental health centre, and it's got everybody on the same email talking together, and has managed to get sort of like a record sheet that everybody's able to go into. That's an extraordinary piece of work, and that's keeping that person safe. And I'm not saying that everybody can do that, because they can't, because it takes an awful lot of time. But I think that term personalized care is bandied around a lot, but very few people do it. And what it means is that that care isn't suiting the system, it's suiting the patient. So you're really thinking about what is it that would actually really meet the needs of this patient. And I think that is an extraordinary piece of work done there. In terms of the food, I mean, we know that the vast majority of people living on the street only have one meal a day. And often that is not the healthiest meal. And, when they go to places which give out food, often it's not appropriate and stuff like that. I don't think I have a good answer to that. 20 years ago, most hostels used to provide food. That's gone now. Very few of those hostels allow people to self-cater. Lots of people genuinely do not understand what healthy eating means, as in they have very, very different views on that, and obviously it's cultural and it comes from their background and whatever. I mean, I think there's a huge amount of work to be done here. If anybody is particularly interested in this area, so we've got at Pathway, there's a year project currently being run by 2 dietitians who are looking into this. They are looking into every aspect as to how we can improve the nutritional status of people experiencing homelessness, both rough sleeping and in hostels, from all sorts of different perspectives. They are extraordinary. One of them works in Bristol and has been giving nutritional supplements alongside methadone pickup, for example, as sort of supervised consumption. So there are lots of ways in which people are thinking about improving people's nutritional status, but it's difficult. And I'm going to shut up now and hand over to Lynne.
Yeah, I mean, it's so difficult, and I think there isn't one page fits all, and I think it's very much looking at, as we all, we try to do for all sorts of healthcare for our patients, is look at that individual person and just see what you can fit in sort of in that person's day. And you're never going to get perfect here at all. I've got many of my patients that are on insulin, that if I'm lucky, if I can just get into them, that we can get them a basal insulin. They still be running high sugars. It's not going to stop complications, because I think you have to look at what your end goal is here. And for somebody that we know in the general population that's starting out the diabetes care, you're looking at preventing, amputations, heart disease, all of those things. But for this group of patients, it's often just making sure we're trying to keep them out of DKA and stop hypos. So for many, I'm working with a gentleman, well, I'm working with 3 gentlemen at the moment, but one in particular who goes missing regularly. He's on the run from the police a lot. He goes for days without his insulin, and he's falling out with his family, and his family is the only people that maybe he used to see. He's been discharged, I think, at Christmas from prison after 20 years in prison. It was 16 years when he went in. He was diagnosed with type 1 when he was in prison, and he's had no support since discharge. So he's never actually managed it himself. So he knows what his insulin is, but he doesn't really know how to manage himself. So we've found recently he's going to his mum's a couple of times a day at some point in the day. So we're just trying to get her to make sure he gets a Tresiba. It's only a small dose of Tresiba, because we don't eat, some days he doesn't eat. And depending on what his blood sugar is, if it's over sort of 14, she's going to try and give him something to eat, and we may get a Nova Rapid dose in as well, and then that's it. And that could be it till the next day or for a couple of days. But it's actually, in the last 6 months, he's not been in hospital in DKA. I don't know how, but he's not. Trying to make sure the rough sleepers team are usually informed, so they look out for him and the others on the streets. We've got the for a couple of them, we've got the local pharmacists where they get the insulin. So again, not every pharmacist will do this, but some will. And again, it's having that personal conversation and talking about the situation. Would they be willing to, again, I guess it depends on the particular guidelines for that particular pharmacy, but we do have some patients that will go and have their insulin from the pharmacy. Our homeless team have like dressings clinics 3 times a week. So for the again, a patient in this position, they are willing to have the insulin at the health centre, but again, that would only be 3 times a week, so it's not ideal. So again, it's looking at what insulin we have prescribed for these patients, and the longer acting basal insulins are better. As Sam said, food choices aren't great. In the ideal world, you would have something well balanced, but I would rather have something eating than not. So just trying to make sure they know where to get some food, and again, that our homeless team are very good at sort of linking in with patients and trying to get them some oral nutritional supplementation. So we've got many patients that have at least one of those a day, which are providing some nutrients, especially for those that are type 3C, because I think you touched on it, Sam. Many of these patients have awful loose bowels, and sometimes it's diagnosed, sometimes it's not, and it could be sort of they have this malabsorption thing going on. So you're fighting a losing battle until you get the gastrointestinal situation, and you're never going to get that controlled until somebody's actually had a diagnosis. So it's very difficult. And I think, this is where you recognise you cannot do this on your own. I couldn't do this job on my own. I'm really good. I'm lucky to have our homeless nursing team, the retinal screener on board. We've got a brilliant specialist for podiatry team who will see patients as soon as I ring up. So it's like linking in and knowing who your contacts are, because, they might be able to have an answer. I meet regularly with our hostel team leads, because their staff turnover is quite quite fast. So we meet regularly to try and update in what we're trying to do, our goals. If they have anybody that's new that's coming into their hostel, inquiring about diabetes, and if they have, I try to get involved as soon as possible. So we're sort of building up this relationship. I think you're just fighting fires an awful lot of the time. I just wanted to touch on one of the issues we have, and I've had it with several patients, because often this is crisis management. So they come into hospital when things are really bad, and we'll find that they've got a situation going on. They've, somebody will call for us. They've not had insulin for days and days. And you go to see them, and you start off, whatever insulin they require, and you give the dose according to what the blood sugars are. But then that's where you start sort of looking into, well, how we're going to manage moving forward. But then many of our patients don't engage very well on the ward. As soon as they get medically fit, they might be leaving the ward, and you then start to get pressure for discharge when you absolutely don't know how they're going to manage post-discharge. And I come up against great difficulties trying to advocate that please don't discharge them. I mean, we can't help it if they walk out the door and don't come back, but please, can we try and have a strategy meeting, try and see what support we can have in the community. And I come up against problems all the time, because they've got capacity to go out and choose to go and take drugs off site. Then they've got capacity to make these choices, and if they don't want to take their insulin, I get told it's their choice because they're demonstrating they've got capacity. So I sort of push for diabetes specific mental capacity, which again is often difficult to have because that might be delayed depending on who's available to do it. But all around specific deeper questions about safe management, at recognizing DKA, how they would treat hypos, how they can work the kit, etc. But that alone itself isn't necessarily going to get them that sort of stay of execution while you try and get a strategy meeting together. And I've had to use cognitive assessments because I think there's several things you have to have together, and anything in the past. So a gentleman that recently I've put a complaint in actually to the hospital. He was discharged despite my efforts to try and keep him in. And this gentleman had learning difficulties. He'd never managed his insulin by himself because he'd been just discharged from the prison service. And he had ADHD and had severe anxieties, which were getting worse. And all of that was ignored because he kept leaving the ward to go and sort of relieve his anxiety in a different way. And now he's been discharged and we're having a terrible time because there's nothing set up. So, and I've had other nurses since the conference contact me with similar issues. This is a widespread problem. But Tamsin actually said we haven't got endless bed space. Once they're medically fit, there is a push to get out, and I do understand that. But this is huge because once they leave us, with nothing set up in place, and even if it's just the fact we could identify where they could get some insulin, that would be one improvement. So yeah, that's something I'm battling at the moment.
Wow, so hard. I mean, you've talked about so many different things that are impacting your day-to-day trying to help these people. I just wanted to ask a bit about mental health because I know that people who are experiencing homelessness often suffer with mental health, and we find that people who have diabetes often suffer with mental health. So it must be a real tricky situation when you've got mental health, homelessness, and diabetes all together. Can you tell us a bit about how that works and if you've got any support around that?
I'll come in first just to say the vast majority of people that we see have had adverse childhood experiences and they've got complex trauma syndromes, which would have been called personality disorder, but we try not to use that. And of course, what that means is that they, you know, they have trouble modulating their behavior, they have trouble trusting people, you know, they often act out. And it's basically because they, because of the adverse childhood experiences, they haven't received, you know, careful and thoughtful parenting and whatever, and they're still stuck in that sort of child mode. And that is by far the biggest impact on them generally. Obviously, as well, you'll get anxiety and depression and sometimes psychotic illness. I mean, you'd probably be aware that for people who have any kind of mental health problem and an addiction, which is often true in this client group, it's not always true, but it's often true in this client group, that it's a vicious circle. You know, you can't get mental health treatment until you quit the addiction. You know, but they, you know, the mental health treatment won't work if they're still using all of those kind of things. So it can be extremely challenging for people. And I think Lynne touches on another issue, or has had, you know, lots of problems in your area with another issue, which is, and as well, we don't have, in terms of safe places to discharge people where we can support them in their mental health recovery, their addictions recovery, as well as all of the physical health stuff. I mean, those placements don't exist. They literally don't exist, and people can be stuck for a long time. Having said all of that, it's really important that people don't feel that just because someone's got a complex trauma disorder, there's nothing you can do. That's literally not true. What is true is that it won't respond to medication alone, and that this person does need time to build up a trusting relationship. You do need to do what you say you're going to do. You know, be that trustworthy person, set reasonable boundaries, but also, you know, if someone's really upset and they're kicking off and whatever, just be calm and sit with it and let them be like that, and then kind of say, well, you know, it's okay. I mean, I think we all need to examine our own views on zero tolerance. But anybody working in the homelessness sector, zero tolerance is, you know, would be very, very different to how a hospital would view it. Clearly, if somebody threw something directly at me, I wouldn't be very happy. But if they're shouting at me because they're not happy with the hospital system, well, fair enough. I feel like that too. And, you know, we've got to let people express themselves, really, in order to build that relationship. So yes, lots of people have got mental health problems, but we have a role to play. They're probably not going to get the support they need within the mainstream system, and that's very sad. Lynne?
I think obviously, as a diabetes nurse, and you work in clinics, you work in the hospital. The way my homeless team work, they have a lot of flexibility, and they can go and they might spend sort of a couple of hours with one person because they actually need it at a time. The way our clinics work, you can never do that, and you've got 20 minutes or you've got 15 minutes, and you're always on this rush. And I think this is one of the benefits of the program that I've set up, and I've set it up in a way that it has to be flexible. I have to be able to go out to the person. I have to be able to spend that extra time. If they miss their appointment at 10 o'clock, I have to be able to say, well, can you come in sort of at 3 this afternoon? I'll fit you in, or I can come to you. And I think what I've found is helping the engagement. This way of working has definitely helped me to achieve what I've managed to achieve in the time that I've been doing it. I'm the only nurse that does it in my at this moment in time in our team. So I always make it as a point that it is me they see. They get my work phone number, and you know, I do have patients that ring on my days off, and I will always answer. I will never say it's my day off, I can't help. I will always find a way. And I think it's, as Sam has said, it's building up this trust that actually you said you're going to do something. You said you're going to be available. and you've met that. And I had a funny, well, it's a bit of a funny story. The other day, I'd got my work phone on, which I know my matron would tell me off because it was my day off, but it was on. And the phone rang, or I'd got a missed call. Didn't recognise it because normally I do put the patient's initials in, so I have an idea who it is, so I'm not being rude when I answer. And I didn't recognise it, so I rang back, and this person had said, "Hi, it's whoever." And I sort of remembered somebody from a couple of years ago when I started the program, and if it was a person I thought I'd spent a lot of time in the hospital with him, and he hadn't been taking his insulin, and I actually got him to understand why he needed to take his insulin at least his long acting once a day, and we could work forward. And then I lost track. And it was this gentleman, and he said, I really need help. I'm in hospital. I can't get a freestyle Libra, and I think that's what I need. I've got black toes because the GP stopped all my insulin, and I don't know what to do. Can you come and see me? So it's like, well, I'm on my day off, but I'll come tomorrow. I'll get a colleague to come and see you. He said, right, I'm on. And he mentioned this ward, and I thought, I don't remember this ward. And he was in Warrington, and I'm in Bolton. So I just said, oh, I'm in Bolton. He said, I know, but you always helped me. And I didn't know what to do. So he rang me. And I wanted to cry, because it actually made me think that for that short time I was with him, I made a difference, and it was giving that time. And I couldn't go to Warrington, obviously, but I gave him some ideas of what he needed to do, and he was registered with a GP. So we would spend 10 minutes saying, look, try this, do this. There was no DSN apparently in Warrington, which I didn't know. They didn't have an inpatient service, he said. So he messaged me back the day after and said, thanks very much. He'd managed to get something from his GP prescribed, and he'd skipped off the ward to go and get his freestyle Libre. And I had another patient that, again, used to be in regularly with DKA or overdose, because that's the other thing we've got to look at. You know, when we're supporting someone to have access to their insulin, if they have mental health issues, we have had patients that come in with overdose of their insulin, and it's trying to get that balance of making sure they can take insulin, but they've also not got, you know, the ability to take their own life. And he started taking his insulin, but he'd also contacted me when he was on the run from the police, and he'd had to leave his hostel, leaving all his insulin behind, and he'd ring me saying if I could leave it somewhere, because he knew I'd help him to get his insulin, and he didn't know what to do, but he was actually on the run from the police. So that wasn't great, but at least he was starting to think of his insulin before anything else. So that's just a couple of my experiences. But with mental health, it's getting that balance, I think, isn't it? And spending time and building up that trust.
Yeah. So, I mean, we could talk about this all day long, but we are nearly out of time. So I just want to ask if there's anything that you want to bring up that we maybe haven't mentioned yet that you want to cover. Sam, I think you might have had something.
Yeah, so one thing I did just want to say is, and Lynn alluded to this, so we do have a 9 times greater suicide rate in people experiencing homelessness than we do in the general population. That is consistent over the last 20 years. So risk assessment around insulin is important. So if you think somebody, you know, if there is a mental health problem and you think there's suicidal ideation, just understanding that is important. I did want to say, you know, our clients, just like any of us, they know whether someone's interested within about 20 seconds flat. They've got really, so, you know, just being interested is important. And then I just wanted to say something a very little bit about unwise choice. So the Mental Capacity Act has led us down this, it's okay to make unwise choices, but within that, it suggests that there is a choice. And the thing is, with, you know, most of our people who are addicted, they're way beyond choice. They don't have a choice. This is a chronic disease. You know, they have absolutely no control over this. And it all comes from adverse childhood experiences. So the Mental Capacity Act has presented us with in its misused, I think, in a lot of ways. So they're saying they're making a unwise choice. Well, they're not making a choice, are they? That's not a choice. And I think we have to really think clearly about the decisions we're making when we're thinking about mental capacity. The very last thing I just wanted to say, which I know Lynne would have mentioned, is use of continuous glucose monitoring in this group across all of the practitioners, the diabetes nurse practitioners, specialist nurse practitioners. There was quite a lot of use of continuous glucose monitoring, not with all of this group, but with some of them. So it's really worth considering because it can be really effective. And sometimes it will be with people you wouldn't expect to be able to use that with.
Amanda, can I just ask Sam just to tell everyone again to make sure they check out the Fair Health e-learning if they haven't already done so?
Yes, very good point. Can we, I don't know how we follow this up, but yeah, so Fair Health has got lots and lots of actually free e-learning modules if you're interested in homeless and inclusion health, but there is one on diabetes. It's been very well reviewed. And also if you go to the Pathway website, which is just www.pathway.co.uk and put in diabetes and homeless, there's a whole set of things there, including some top tips, crib sheets, some advice on how to do like access audits in your area, and all sorts of different things. So do go and have a look. Thank you for that, Lynne.
Okay, and Lynne, do you have any final words for our audience?
It's just if it's not something you've actually thought about doing, it can be really daunting, but just start small and just start looking at what changes you can make in this cohort. Just small can grow bigger, and it's never not going to be worth it.
Camden, any final words?
No, I'm always impressed by people's passion about something that we know is an issue, but not all of us can obviously do something about it. But I think, as you've said, that anything that we can do actually will help these people. So even if it is something as simple as asking for a continuous glucose monitor, which we do all of the time, don't we, for our cohort of patients, even if it's something as simple as that, and saying, can that be provided, that at least gives them something, doesn't it, to be able to say what is going on with their blood glucose levels. And hopefully that then triggers a little bit of the process of, I need to take insulin, and if I don't take insulin, something might happen. And maybe it is just those little small steps, whereas if they don't have a meter, they never know, do they, what their glucose levels are.
Oh. Okay, I just want to say a really big thank you for being our guinea pigs as well today on our first YouTube live. Thank you so much. It seems to have gone well. So I just want to say a big thank you for that, and thank you for sharing all of your stories today. Really, really powerful stuff coming out there. So if you would like to keep updated with stuff that the DSN Forum does, please do subscribe to our YouTube channel so that next time we go live, you'll get a notification that we are live and you can come and join again. So I want to say a big thank you again, and goodbye, everybody.
Bye.
Bye. Bye-bye.